Good afternoon, everyone. Welcome, everyone, to the HSC Office for Diversity, Equity, Inclusion Native American Heritage Month event. My name is Dr. JP Sanchez. I serve as the Executive Associate Vice President in the office. On behalf of all of us in the HSC Office of DEI and Vice President Dr. Romero Leggett, we'd like to thank you for making time to join us for this very important session. For those who are not able to join us here today, this presentation will be recorded and posted on our HSC Celebrations website. Just want to go over a few housekeeping items. Please place your questions in the chat at the bottom of your screen. We will try and address as many as we can at the end of the presentation. Questions, comments, thoughts. Please also take a moment to complete the pre-assessment that has been placed in the chat box already by our own Dr. Swan. This will help us understand your interests and reflections during the month. As you all know, we are joined today by Dr. Mary Owen, who, let me just start off by saying, is such a great colleague and a friend. I got to meet Dr. Owen as a participant in the AIP annual conference, the Association of American Indian Physicians annual conference, where you can go and learn about the latest Native American health disparities, but also innovations and meet community members from across the country. And she has served as past president of the Association of American Indian Physicians. She was also recently recognized with the GDI, the AAMC Group on Diversity and Inclusion Exemplary Leader Award recently for her longstanding work in support of Native American communities, but all diversity communities. On the HSC Celebrations page, you will see, you will read and learn a little bit more about Dr. Owen. I'm just going to mention, she is a member of the Aquan tribe of the Tlingit people. She is the Associate Dean of Native American Health at the University of Minnesota Medical School. On graduation from the University of Minnesota Medical School and Family Practice residency program, she returned home to work for her tribal community in Juneau, Alaska. Did I pronounce that correctly? Juneau, Alaska. In 2014, after 11 years of full-scope family medicine, she returned to the University of Minnesota Medical School, Duluth, as the director of the Center of American Indian and Minority Health. Her work includes developing regional and national programs to increase the numbers of American Indian Alaska Native students entering medical careers, outreaching to local and national Native leaders to ensure that the University of Minnesota Medical School remains in tune with the AI/AN healthcare and educational needs, teaching medical students and healthcare providers important components of providing healthcare to AI/AN communities, and developing research efforts to address AI/AN health disparities. She continues to provide clinical care at the Center for American Indian Resources in Duluth, and as mentioned, the immediate past president for AAIP, and is just leading this country with her colleagues and helping us understand what we need to do to better integrate Native American content into our osteopathic and allopathic medical school, UME and GME curriculum. So thank you so much, Dr. Owen, for joining us. It's as always, a pleasure and honor. Handing it over to you.
Buenas dias, Dr. Sanchez. Ludash uchat tuasak. My English name is Mary Owen. I am, as Dr. Sanchez said, Associate Dean of Native Health over here at the University of Minnesota. My Tlingit name is Ludash. I'm named after my grandmother, and I'm part of the Thunderbird House of the Shark Clan of the Aquan tribe of the Tlingit people from Southeast Alaska. And I'm honored to be here and invited to be here today to talk about something that's really important to me, and that's improving the health outcomes of Native people, all people, but this is just one piece of that. And I'm going to share my PowerPoint now with you. Oops, I did it wrong again. Go back to Zoom and share screen. Okay, which one are you guys seeing?
This is the correct one.
Okay. So my work in general, as was stated earlier, is increasing the number of healthcare providers in Indian country, particularly Native healthcare providers. IHEAL, this is an initiative that I started when I was the president of the Association of American Indian Physicians, and it's to address the fact that we have no numbers of increasing, we don't have increasing numbers of Native Americans hitting the door to medical school to gain entry and become physicians. And we have that problem in all of our health professions. It also stems from, slide here, our health disparities in general, and that's what this talk will focus on today. So the objectives of our talk today, really just to talk about IHEAL, one effort to change those numbers, to expand IHEAL, and then to start to increase the numbers of Native Americans advancing in academia. And that's what that last bullet is: introduce and support an IHEAL writing collective. As we all know, to advance in academia, you need to be writing. So it's to support that work. But getting to why IHEAL is important, at the bottom of everything that we do, or everything that I do at least, are these health disparities. And these are the life expectancies for years 2019, 20, and 21. And you can see from that last, we're on the far right there at 71.8. We are already below the national average for lifespan, but that worsened significantly, and the disparity grew with COVID. And what's not reflected on here, you see the green line is our lowest number in 2021, but that doesn't reflect the fact that this is just an average for men and women. Our men die on average by age 62. So again, the whole reason for everything that some of us are doing what we do. That life expectancy is for many reasons. I'm going to discuss a couple. One of them is lack of access to health care. This is a slide from the 2018 Government Accountability Office that shows the healthcare professionals in different IHS clinics and hospitals throughout the regions of the United States. I live up here in this Bemidji area at the bottom of Lake Superior. And in this area, we have a physician vacancy rate of 46% for the IHS clinics, similar to over here in the Northern Plains. And you can see that we're not well represented anywhere where we have significant numbers of Native clinics. Alaska and California, we can't tell, we don't have the numbers on because these are not IHS clinics. These are tribally run clinics in both states. Some people will say, well, you probably have other healthcare providers who can step in, and that's not the case. We're short as well of other allied health professionals. I think that's the right term. I apologize if it's not, and I've misnamed somebody. The other reason that we know that our patients are not doing well is mistrust, and all of us in Indian health and other people of color in general can speak to mistrust in our communities. We don't need that we need the anecdotal evidence, but behind that, we also have plenty of evidence that shows that this long history of mistrust occurs in our communities. So how do we respond to that? Well, we increase the numbers of healthcare providers from our own communities, right? Grow your own. Rural communities do the same. They try to grow more rural docs to serve rural needs. The problem is, if you look at this top line, this is American Indian Alaska Native men and American Indian Alaska Native women graduating from medical school. The problem is that in 4 decades, this is only a few years, but we know that this data is similar for 4 decades. The numbers don't change. Our numbers of Native physicians graduating every year is about 40 out of 20,000 total. So again, we are the population that would probably have the best luck at serving and best outcomes at serving our communities, but we're just we're not well represented. So hence the reason for the work on the curriculum. I've got these slides in a certain order that made sense to me at the time, but I'm going to skip ahead a little bit to show you something else first. Our IHEAL, Indigenous Health Education and Learners Alliance, Health Educators Alliance. I'm sorry, I'm thinking about IHEART. There are 2 different groups that I'm going to tell you about today, and I always get their acronyms messed up. But this is the background. This is why IHEAL exists, because we have so much higher rates of mortality and morbidity than other populations. We know from COVID, for example, that our mortality rates were 4 times that of white populations, similar to what happened with H1N1 in late 2009. We know that part of it's access to care, but that includes access to quality health care, which would presuppose some representation by those people who are from the community, right? We know that there's significant misunderstanding of American Indian Alaska Native people, including our culture, our history, our demographics, and importantly, the milieu that we sit in, the fact that we are second-class citizens in this country. That's important to know when you take care of us. Knowledge of who we are, that history, the racism that exists still, and then the lack of curriculum that allows providers to have something to challenge those narratives that exist about us. For those people who have been in an emergency department and seen or experienced the racism, you know well what we're talking about. It'll take a lot of curriculum, at least some curriculum, but ideally curriculum that is longitudinally placed to help counter some of those negative stereotypes. So I'm going to go back here, and I apologize for this mix up. This just makes more sense to me now as I'm going through it. So IHEAL is fashioned after, it wasn't a unique idea. It's fashioned after what Australians and New Zealanders have been doing for 20 years now. They have built something called the Leaders in Indigenous Medical Education, or LIME. This is their website that I would encourage everybody to take a look at. It's incredible what they have done in 20 years. Essentially, they recognize the same things that we did: high disparities for Indigenous populations, and recognize that we needed more education about who Indigenous people are in our health curriculum if we were ever going to start to change those disparities. So they started coming together in the early 2000s, and by 2008, I believe, actually had a framework for a curriculum. And by 2000, at least by 2014, if not earlier, we're starting to place that curriculum in all of their medical schools throughout Australia. So again, that's where this idea came from. And I'll remind you that IHEAL was developed in response to our having met AAIP, Association of American Indian Physicians, having met with the AAMC, Association of American Medical Colleges, and other interested groups who wanted to address the workforce shortages for natives in this country. So we'd been meeting for several years in a row and talking over and over about the problems, but we weren't coming up with any solutions. So IHEAL is modeled after the Lyme Network to try to address this. IHEAL and iHeart. I'll tell you more about both in a second. This is right from their website. So again, if you click here on their website, you'll see the different options, including their resources hub, their students, colleges, and I believe their resources hub is where I found this next one, and it's their curriculum framework, which IHEAL is also modeled after. An overview of their efforts: they wanted to audit the Indigenous health content in core medical education. They've long since done that. Develop a nationally agreed curriculum framework, which they have done. A network of Indigenous and non-Indigenous medical educators concerned with Indigenous health, and accreditation of the curriculum framework by the Australian Medical Council, all of which they have now accomplished. And their guiding principles, you can read through those on your own, but I want to highlight one on the bottom here that I think is really telling. The health outcomes of Aboriginal and Torres Strait Islander peoples are governed more by the historical and social determinants of health. Are governed more by the historical and social determinants of health than with inherent aboriginality. So governed more by the historical and social determinants of health than with inherent aboriginality. Prior to colonization, Indigenous Australians were healthy and maintained physical, emotional, mental, and spiritual welfare. Thus, the prevalence of illness in today's society cannot easily be attributed only to genetic or even behavioral causes. Rather, as supported by evidence, the preferred view is that current health outcomes result from a range of interrelated historical, environmental, physiological, political, and behavioral factors. So what I like about this is that it tells us that this framework for Indigenous health, I mean, the whole thing is brilliant, but this piece for me is critical because it says the framework isn't just telling people about our culture and how our culture used to be, and things that I too frequently see that romanticize who we are as Indigenous people. They're saying that this curriculum must also contain the habitat, the milieu that we now exist in, and has to talk about things like the poverty levels and how that affects us and affects our culture and our practices, and education and how that has and continues to affect us. So this is a very broad curricular framework, which is absolutely key to making change. So this is that background I talked to you about, the background that we use for IHEAL. And then some of the key principles that we are incorporating, also based on the principles that Lyme used. That academic health centers must value Indigenous communities, cultures, health systems, and practices that promote health and healing. So getting more to not just recognizing Indigenous culture, but practicing our ways throughout the academy. Academic health centers understand and recognize tribal sovereignty and the status of tribal nations. Obviously, colonization is a fundamental determinant of Indigenous health. Continues to impact us in numerous ways today and impact our healthcare. Colonization is a structure that weaves racism, bias, and discrimination throughout societal systems, including education, health, social justice, economic, and housing. Again, a repeat of that, similar to what we just read from the Lyme work. The development of and persistent support of colonization necessitates exploitation of and co-opting of Indigenous lands and replacement of Indigenous ways and knowledge with beliefs, values, and education of the colonizing people. Decolonization of medical institutions necessitates that medical institutions have a framework for acknowledging their historical contemporary role in the exploitation of Indigenous land, eradication of Indigenous ways and knowledge, all of which maintains unequal relationships between Indigenous people and Euro-Americans. So Dr. Sanchez mentioned at the very beginning of this talk, maybe before a couple people came on, about the changes that we are starting to see in academia. And the fact that we can write down these key principles, you know, who knows, it might be another 10 years before they're broadly accepted, but that we're able to start talking about the impact of colonization on people, recognizing what colonization is. I'm having those discussions with my students now. And what does decolonization actually look like? It doesn't mean just dropping in a couple of classes on Native culture, but a much more in-depth understanding of how culture got erased and replaced and what it was replaced with, and starting to detangle all those things that we presume now, right? That have become part of who we are because we were all raised in this system. So the overall objectives right now, at least, of IHEAL are to increase awareness of Indigenous health, talk more about it, create standards for caring for Indigenous populations, almost like I forget what we're calling them in academia, but they're the learning capacities that we all have to, skills that we all have to meet. Create Indigenous health curricula for all health training institutions. You know, we're talking about starting with medical school and residency curricula, but long term, we want to hit all clinical and health systems and have all providers trained within them. Incorporation of and all of these efforts have to incorporate local resources and knowledge. So I'm in Ojibwe country, Anishinaabe country right now. I won't be teaching about Tlingit ways. I mean, I might mention some and do some compare and contrast, but most of the teaching will be by and for the Anishinaabe here. Increase pathways to health professions, academic leadership. We need to be able to teach these materials. We need them to be guided in a good way. We need them to be guided by Indigenous people. So we need more of us in the academy. And we don't always have to be the teachers, but we certainly have to be guiding the material and making sure that the people who are teaching them can respond to the questions that are natural that come with them, or know where to direct those questions afterwards. And this is where we are now. We're looking at, we hope to have, oops, what happened there? We hope to have an audit or publish on an audit of the literature that exists now on Indigenous health education or curricula. We are publicizing those, or publicizing, I knew that word looked funny. Anyway, we're publishing the key principles of Indigenous health sometime within the next 6 to 12 months. We are also going to be publishing this Indigenous curriculum framework, as we saw from the Lyme model. We have our own version of it. And we will be continuing to support Indigenous faculty scholarship, and part of that is through this IHEAL writing challenge, or work that encouraging others to join the IHEAL work group and start to write, so that we can both mentor people advancing in academia, but also to help them get their pieces published, their work published. And we are also aligned with iHeart to increase the numbers, the regional pathways for kids from Native kids in grades kindergarten all the way through grad school. And this is just an image of what iHeart looks like. iHeart also was started from when I was president of AAIP, and also in response to the shortage of the workforce. And this is a schematic of it. We have a national hub that directs these different regions to connect pathway programs within those regions, so that we get our kids advanced. We need to have longitudinal support for our students. We know that there's so many different ways that they can fall off. And that is it. And I will now move to questions. Stop sharing. Okay, short talk, lots of question time. So JP, you had some questions, and do we have any other questions?
Yes, so as Dr. Swan mentioned, for those who are able to join us today, please post any questions in the chat box. For Dr. Owen, I'll be able to read it off. So I'll just start us off with two questions, because we've spoken a lot, Dr. Owen, about why it's taken so long to bring us to this point. Maybe you can share with the community why you think it's taken till today to reach a new plateau of the integration of content related to Native American health and inequities for our medical schools, because you've been doing this work and with ANAMS and AIP. What are the factors that are playing out differently now that put us in a better position?
Well, one significant factor, I mean, if you was COVID, right? It kind of blew open the numbers. So everybody had to see, even though we weren't even on the graphs when you first saw them being reported, we did eventually make it, and there was a recognition of how poorly we were doing because of COVID. And then people started to go backwards and see that, hey, wait a minute, this has been affecting them for a long time. So there's just been a lot more discussion about that in the past 5 years. But we'll continue to face challenges, because our population is so small, because the US government did such a great job of wiping us out, right? And so we just don't have the numbers to be able to fight for and demand that justice. And but other things that are making it is I think more feasible now is that we are starting to get Native leaders in academia. We have 5 big centers. 3 of the leaders of whom I will mention to you all graduated from the University of Minnesota, but that's another aside. Yeah, so our programs are growing, and while we are not by the numbers showing a lot of increase, we know that that we are starting to see a lot more interest and students demanding more of this curriculum, the students who are coming out these days. So that makes a significant change, I think. Even the curriculum that I give today, and I've been doing now for 8 years, students will sometimes say, and then what's more? They want more. They want it much more in depth. So there's demand, there's recognition of the disparities, there's a teensy little bit of increased leadership by Indigenous providers, in these spaces. There's some of the factors that have helped.
Great.
What do you think? I'm curious what you see, because you've been doing the same work.
Well, I think what you highlighted, absolutely. It's unfortunate that it took another pandemic to see the disparate burden of disease on historically minoritized communities, like our Native American and Native American communities. I think that you're right. In addition, having now more Native American leaders move outside of DI into research, into education, into student affairs, into more roles, better positions the community to see these changes in that is difficult to happen when it's only situated in Office of DI, right? You need colleagues to help see it through in the other pillars of our academic health centers and medical schools. So I think what you commented on and seeing so many great leaders come through Minnesota, playing now additional senior leadership roles, builds a stronger group in many ways. I think that I think the change around social activism, white coats for Black and Indigenous lives, also moved the discourse to a new level.
Yep, our students, yeah.
And the AAMC has also taken a new level plateau by specifically listing in their strategic plan efforts to address health equity for Native American communities. And I think this is the first time that, in my knowledge, that it was specifically articulated within the AAMC strategic plan, because then that also ramps up investment of resources through AAMC. And then they also encourage their member institutions, all of the allopathic medical schools. And I think that AIP, and correct me, please, that I think, and I was going to bring this up as a question, do you feel like there's been more of an openness by AIP to focus on curriculum, right? Like, I think there was a lot of emphasis on getting students of Native American identity into medical school, but I hear now more of the AIP leaders talking about let's also work on curriculum, and that's become more of a focus even at the conference. But I want to ask you, do you feel like the leaders within the community are also viewing curriculum differently?
I absolutely think so. And I think it might have to do with the fact that so many of us who are in the leadership of AAIP are also in leadership positions in our medical schools. And so naturally, we're recognizing the absence of that appropriate curriculum and we're demanding more of it. And AIP sometimes has been supportive of more work around academia and other times less so, but right now definitely wholeheartedly. Regarding what you said about AAMC, that's so true about the support coming from them. I think that they have tried hard for a long time, but I think that they've been able to grab onto IHEAL and to iHeart and support us. Namely, I mean, that primarily is from Norma Pole Hunter, and who has helped us even secure funding from major funding for iHeart now. But she's also attached us to, or brought us to the front with academic medicine and gotten us some opportunities there to help spread the word. So her advocacy and the AAMC in general, but particularly her, has been phenomenal and helped support this work. Regarding your comment about DEI, it's funny, I take it for granted because our program has existed for 50 years and we were never under the umbrella of DEI, which of course DEI is really important work, but it's work that we work alongside of. We've never worked under an umbrella. And I would argue that we need to be alongside because of exactly what you just said. One, our numbers are too low, and two, we are the original people of these lands and it looks a little bit different. We have maintained our culture in a unique way that has helped us survive. And again, it has nothing to do, it's not personal, it has nothing to do with other communities. We support them as well. But this is really important that we not be under that umbrella.
And how can people get involved? I think a lot of people are actively teaching, developing curriculum, but what are the best ways for them to get involved in this revolution around curriculum development?
They could join IHEAL, particularly if they are if they're native scholars. That's what IHEAL is for. We have to keep it that way for now. They can also be involved in IHEAL. You can contact me through, I think you have the contacts information, and we could put that in the chat as well. for iHeart is, and we're welcoming curriculum even in iHeart, of course, because iHeart is those pathways to get our kids at every moved up through every step of the way, and curriculum is key in that area as well. So if you wanted to join iHeart, particularly for the Southwest region, the person leading it right now is Dr. Adrienne Begay. So you can send an email to that same address, and I'll connect you to your regional iHeart collective or efforts. Those are some ways. The other way is to connect with the local school and ask them, what are you teaching? What are you teaching about Native people? Because so much of our work in iHeart deals with the fact that most schools don't teach much about Native health, if anything at all. And a lot of what they teach, and I'm talking K through 12 right now, a lot of what they teach happens to be about Wounded Knee or Trail of Tears. It's not about Native people and how we've survived and how we continue to thrive in lots of different areas today. It doesn't talk about Native doctors. It doesn't talk about efforts that we're involved in that are really positive for our youth. And as we all know, that just if people don't hear about themselves or know about who they are and that they're valued, they're not going to do as well. Those are just a couple of ways, but I think that last one is really important. We all need to be getting involved in our local school system and finding out how our kids are doing. Like in Duluth here, the high school graduation rate for Native kids is 43%. So you can't avoid that work.
Now, one of the things that you mentioned that was really important is that primarily the cohort of individuals that you're working with or individuals who identify as Native American or Indigenous. When we think about the dissemination of material, I know historically, within the teaching world, some people feel like certain content can or should only be taught by individuals of that community. But then there's also an innate challenge in that with the current proportion of Native American faculty and 200 medical schools, what has been the discussion around you create this fantastic curriculum? How do you get it actually activated and taught across 200 medical schools who each have 4 years of medical students and then GME as well? So what have been some of the early discussions around, the teaching, who gets to teach, and how do you disseminate it?
It's such a great question. Thank you for it. It gets into the meat of our work, so to speak, or the vegetables of our work if you don't like meat. And it's we first of all don't imagine or don't think we should necessarily be required curriculum for all medical schools. In a beautiful world that would exist about all populations, but we don't live in a beautiful world. So it should be curriculum, though, that is required in medical schools where we have significant populations, right? And that's not necessarily just on the West. I just was out in Syracuse and they have a huge Native population, and so it should be there. But anywhere where you have large numbers of Native people who still exist on their land, and you're going to see them in the hospital. So hospitals and clinic settings, it's absolutely critical that they have that. So that lessens the number of medical schools that would have it. The other thing is that we are encouraging medical schools to recognize that experts aren't just you and me, JP. Experts exist in our community who know our culture very well, who know the impact of poverty on our houses. They know what that education rate does. They know all these things, and they know our culture. They are the experts. Just like people, we don't talk about it, but we don't give our students enough expertise on their culture. There are all these experts around us that aren't recognized in our system of academia, our crazy hierarchy. And so we expect our schools to go out and find some more of those experts, and that will also help them learn more about the local community, which is so important. We can't do this work in a vacuum. So 1, less numbers of schools. 2, redefining how we see expertise in this system. Those are the big ones.
Excellent. So any final thoughts before we close out? Any final thoughts or hopes as we move forward?
Final thoughts, just that this work is like iHeart. It's a huge effort still. We've just begun. It feels like we are flying the plane as we are building it in both cases, iHeart and IHEAL. And we're going to need a lot of different support because like you, JP, all of us are pulled a million different ways. And so this is one project I have a whole book of projects that I'm working on. You know, we know what that minority tax looks like. We're not saying other people don't also have their own taxes, but we're always getting pulled into different things because there's not enough representation of brown people in general in our schools. So we need lots of help. Please join this effort. And if you don't have the effort to do that, then just start asking questions. You know, what's happening with this population? Why are these disparities existing in education, in housing, in any area? But get active would be my final thought. I hope people do.
Excellent. Well, thank you again, Dr. Owen, for joining us. For those who are able to join us today, please take a moment and fill out the post-session assessment. And most importantly, support and help Dr. Owen and the IHEAL and iHeart communities in this important innovation. Thank you, everyone, for joining us, and be on the lookout for the next events for Native American Heritage Month. Take care.